how to connect. I'm just going to connect these two lectures where you have decided your research question or your objectives and try to find the suitable study design that will enable you to answer those particular questions. So let me share my PowerPoint slide. Please feel free to type in your queries in the chat box. I'll be more than happy to answer them at the end of the lecture. If you want to raise your hand and ask any question in between also, I'm fine. There will be some points where I would be requesting your inputs. If you have an answer, you can type it in the chat box and I can review it later. So let's, without wasting much time, let's move ahead. So the title is Identifying Appropriate Study Design for Epidemiological Studies. We are going to look at 3 important and commonly used study designs in epidemiology: cross-sectional study, cohort study, and case control studies. So the learning objectives for this particular session will be, at the end of this lecture, you should be able to identify study designs that are appropriate to the research questions that you have already designed or you already have in mind, and describe the strengths and limitations of each study design and understand which study design is suitable for a given situation. And if you choose a particular study design, what are the advantages and the limitations of that study design? So these are the 2 broad learning objectives for this session. There are 2 situations which you might come across when doing epidemiological studies. The first situation is where you only observe events taking place in the study participants. Okay, you are just observing, you are not doing any sort of manipulation or intervention in the study participants. So that is merely observing. The second type of situation is where you apply an intervention and examine its effects on, examine the effect of that intervention on subsequent events. So that is where the researcher tries to do something, manipulate something that is going to change the clinical course or that is going to change the behavior of the participants. So these are the 2 broad situations. One is merely observing and the other one is doing an intervention. So based on this particular phenomena, we can divide the study designs into either observational studies, where you are only observing the study participants, whatever is happening naturally without any intervention. The second situation is where you apply an intervention. Those are called experimental studies. So your classical clinical trials, randomized control trials, all those will come under the second part. Today, what we are going to see is exclusively observational studies. So usually what happens is when you are trying to do an observational study, there are 2 steps in doing an observational study. One is called the descriptive and the second one is called the analytic. What is descriptive? Descriptive is very exploratory in nature. What is the level of consumption of dietary fish in individuals with a history of CHD? So it merely tries to understand a phenomenon without trying to associate any exposure with any outcome. So there are no comparison groups. You are only trying to explore a particular phenomenon in great detail. So that is exploratory in nature, which we also called descriptive. The second part of observational studies is analytical, where you evaluate association. So whenever you use the word association, risk factor, associated factor, factors associated with, so whenever you use terms like this in your objective, you are looking at an analytical observational design. So for example, is there an association between fish intake and risk of recurrent myocardial infarction in patients with a history of CHD? So I will pause here for a few seconds because the understanding the distinction between these 2 is very important. So on one hand, I'm saying that you are only doing a description of the events that is happening without trying to find any association between variables. So that is descriptive. The second part of that is analytic, where you evaluate the associations between exposures and outcomes. Why the title of this slide is sequence is because you cannot go directly into analytics without first doing a descriptive. You have to understand a particular phenomenon by doing a descriptive study design, or somebody has already done a descriptive study design. Then you move on to an analytical study design, where you try to go in much more detail of the details of the phenomenon. So try to understand the distinction between descriptive study design as well as analytic study design. So it helps to go through a flow chart. Descriptive studies generate hypotheses for associations between risk factor and the outcomes. So they do not confirm, they simply generate ideas or hypotheses, whereas analytical studies use comparison groups to establish the association. So they are more confirmatory in nature. If you have done a descriptive study, at the end of the descriptive study, you will be able to generate some hypothesis that factor A may or may not be associated with the outcome. But when it comes to analytical studies, you are going to establish that hypothesis. You are going to definitely say that factor A is associated with the outcome or factor A is not associated with the outcome. So descriptive studies deal with questions like who, what, where, and when, whereas analytical studies try to deal with questions like why and how. So if your research question has words like who, what, when, and where, you are looking at a descriptive study. If your research question has why and how, then it will probably be dealing with analytical study. So it helps to go through a flow chart. The different study designs that we have discussed so far, I'll help you understand where they stand in the overall scheme of study design. So the first question we ask is, did the investigator assign exposure? If the answer is yes, then it means you are intervening. Therefore, it is an experimental study. If the answer is no, then you are simply observing, and therefore it is an observational study. Within the experimental study, if you are randomly allocating patients to receive or not receive the treatment, it becomes randomized controlled trial. If there is no random allocation, it becomes non-randomized controlled trial. So we are not going to look at this part in this session, so I'm just going to hide it. Once you have come across an observational study, you are going to ask, is there a comparison group or not? If there is no comparison group, as I said in the previous slides, it is going to be a simple descriptive study. So you are going to only describe a particular phenomenon in great detail without any comparison groups, and there are no association findings. If you have a comparison group, then it becomes an analytical study. And there are three major types of analytical studies, depending upon the direction of inquiry. So if your direction of inquiry is exposure to outcome, then it becomes a cohort study. If your direction of inquiry is outcome to exposure, then it becomes a case control study. If your exposure and outcome are measured at the same time, then it becomes an analytical cross-sectional study. Now, please remember, cross-sectional study will come here as well as here. So descriptive studies are also called cross-sectional studies without an analytical component. But if you had an analytical component, you would also put it under the analytical study design. So that is how we classify the different study designs. We are going to see these three study designs in great detail in the subsequent slides. So first, let's look at a cross-sectional study. So as you must have come across this term many times during reading textbooks, it is a study or survey conducted at one point in time in a cross-section of a population. So on the day you collect the data, whatever is existing, you are going to capture. There are no independent comparison groups used. So there is only one group in which you are going to collect information. You can make comparison groups after the data collection is over based on the data that you have collected. It does not permit conclusions of association between exposure and outcome or disease. There are a few exceptions where you can make conclusions about association where you have a preconceived idea about blood groups or genetic markers or gender. For example, we know in the population, men and women are 50-50%. So in your study, if you want to see an association between gender and some outcome, you can still do it because you know the gender should be 50-50. So apart from these situations, case control studies cannot be used to determine associations between exposure and outcome. So the important feature or the main thing to note here is there is no independent comparison group, and it is conducted at one point in time, and it is a cross-section of the study population. So these are some of the study questions that will be answered by cross-sectional studies. What is the prevalence of substance abuse in Chandigarh? What is the prevalence and distribution of risk factors for coronary heart disease in rural Tamil Nadu? How satisfied are patients attending public sector secondary care facilities in a particular district or state? So you can see from the questions asked here, these are mostly exploratory in nature, or they are going to estimate one particular phenomenon in a particular population. So there is no comparison group and there is no estimation of factors associated. This is another question where we can answer by using a cross-sectional study. Who is most affected by COVID-19? So what are the types of people who are affected by COVID-19? This can be a hospital-based cross-sectional study in one group of patients. It is a simple description of patients with respect to their socio-demographic and clinical variables. It can also tell you the profile of the affected person. For example, most of the COVID-affected persons were 60 and above. Majority of the COVID-affected persons were males. Majority of the COVID-affected persons were coming from the urban population or from urban residents. And the results of these cross-sectional studies will be described in either frequency or percentages, mean and standard deviation. So these will be the outcomes of a cross-sectional study. Another example, what percentage of the population is infected with COVID-19? So as you know, we conduct large COVID sero surveys to answer this question. So it will be a community-based cross-sectional survey using a representative sample of the population. Again, whatever you are going to tell as result will be in the form of frequency, percentages, mean and standard deviation, prevalence, or 95% confidence interval. So please remember, whenever you are doing a cross-sectional study, you can only estimate prevalence and not incidence, which is the occurrence of new cases. So frequency, percentage, prevalence, 95% confidence intervals is what you will get if you do a cross-sectional study. These are some of the strengths and weaknesses of cross-sectional studies. They can estimate prevalence. They can determine the distribution of a particular disease by time, place, person, or a particular risk factor by time, place, person. It can identify priorities for disease control. So you have to invest on those diseases which have a higher prevalence, which affect more people, and so on and so forth. They are used to generate hypotheses. Again, please remember, this is an important distinction between cross-sectional studies and the other two study designs we are going to discuss. Cross-sectional studies will only generate hypotheses. They cannot confirm hypotheses. It can examine evolving trends. So if you want to understand how a particular disease or a risk factor, say tobacco smoking or tobacco chewing has evolved over the past 30 years or the past 10 years or the past 5 years, you can look at trends by doing a cross-sectional study. They are usually quick and cost-effective unless they are very large or nationally representative, in which case you will be needing more money and it will also take time. But in general, they are quick and cost-effective. Some of the weaknesses of cross-sectional studies are they usually provide low level of evidence for association. So you must be knowing the hierarchy of evidence, where we start at the bottom with case reports and case series, and at the top there is systematic review. Generally, cross-sectional studies have on the lower rungs of level of evidence, and there is temporal ambiguity. What do I mean by temporal ambiguity? Since we are measuring the risk factor and the outcome at the same point, we don't know which comes first. So it is like the chicken and egg scenario. We don't know which came first because both of them were measured at the same time point. A famous example of a Boston surgeon is given in textbooks, where a famous practicing surgeon in Boston was giving a lecture to a group of students, and he said that I have operated on so many patients, and this is how my patients have fared. So one student who was sitting at the back of the lecture hall asked the surgeon, "Did you have any controls? Did you have a group of patients whom you did not operate on, and did you look at their outcomes?" The surgeon got very angry. He said, "Do you mean that I did not operate on half of my patients?" Of course not. They would have been doomed to their death if I did not operate on them. The student then silently asked, "Which half?" So what the student is trying to say is, if you don't have controls or if you don't have a comparison group, you cannot tell whether the treatment worked or not, or whether the exposure is actually associated with the outcome or not. So this is a good place to start our other two study designs, where we talk about comparison groups, and in general they are called analytic study designs. So first, let us look at cohort study. The word cohort comes from a Roman legion. So where one group of soldiers or soldiers belonging to a particular regiment, they are called a cohort. That is where we get the word cohort from. So they share certain similar characteristics. So that is why they are called a cohort. So group of individuals defined on the basis of whether presence or absence of an exposure of interest, and they are followed over time to compare their risk of developing one or more diseases. So please remember, the starting point for a cohort study is whether a particular person is exposed or unexposed. So you might start with two groups. One group is exposed and the other group is non-exposed. These individuals are free of disease at the time of enrollment in the study. This is another important point where we set up a cohort. None of the participants should have any signs of the disease you are interested in at the time of enrollment. If your disease of interest is, say, multiple sclerosis, or if your disease of interest is, say, COVID-19, or if your disease of interest is rheumatic heart disease or rheumatoid arthritis, those cohort which you begin with should not have the disease of interest. You are going to see over time how many people in your cohort developed that condition or disease. So these are the two important preconditions to set up a cohort. So the individuals are defined on the basis of presence or absence of the exposure, and they are followed up over time to see the development of diseases. One scenario where we can start is called prospective cohort studies. So these people are exposed, these people are unexposed. This smiley face represents you. You are the researcher. So after the exposure has happened, you are here and you are going to look into the future to see whether disease is occurring or not. These are called prospective studies. None of the participants have the disease when you are entering in the study. So exposure and non-exposed people are here. You have started observing them and you are going to look into the future to see whether they developed the disease or not. The counterpart of this is called retrospective. So the exposure has occurred, the disease also has occurred, but you are now looking back into the past and you are going to recruit patients based on whether they have exposure or non-exposure, and you are going to follow them in time, that is in the past time, to see whether they have the disease or not. So how is this possible? This is possible when you are doing a record-based study. Imagine you are in a hospital and you have records of, say, thousands of patients who are given a particular treatment and those who are not given that particular treatment, and their outcomes are recorded in the medical records or the case sheet. And you are going to follow them up in time, that is the past time, and you are going to see how many of them developed the disease. So here the difference is you are here, the investigator is here, both exposure also has occurred, disease status has also occurred, but you are going to look back in time through medical records and see how many exposed to develop the disease and how many non-exposed to develop the disease. So these are the two ways of doing a cohort study. One is prospective and retrospective. Examples of cohort studies. So estimation of incidence of cardiovascular diseases in the Framingham study population was a prospective cohort study. Food outbreaks investigation in hostels or any other workplace settings can be considered a retrospective cohort study, where you go after the outbreak has happened. Everybody has eaten some food, everybody has developed it. Some of them has developed diarrhea, some of them did not develop diarrhea. The outbreak is now over, but you are going back to the hostel and trying to collect some data about the past event, and you're trying to find the association between eating a particular food item and having diarrhea. All clinical trials are cohort studies because they have the follow-up element, but clinical trials are different from cohort studies because they have an intervention component. That is, the researcher is going to intervene. So in that sense, they are cohort. This is an example of a research question which can be answered by a cohort study. Does COVID lead to long-term health problems? So it is a cohort of a single group where you recruit all patients who have COVID and follow them up in the future. There is no comparison group, but you can estimate the incidence of specific conditions during a follow-up period. So out of say 1,000 people who had COVID, 5% developed headache, 10% developed memory problems, 5% developed body ache or something like that. So in such designs, you can estimate incidence and 95% confidence intervals. So please remember, in cohort studies, we can calculate incidence and confidence intervals, whereas in cross-sectional studies, we estimated prevalence and 95% confidence intervals. This is an example of another study question which can be answered by a cohort study. What are the risk factors of mortality in hospitalized COVID patients? So it can be a hospital-based prospective cohort study where the risk factors for specified outcome are identified by following up the patient. And it proceeds from exposure to outcome, and biases due to loss to follow-up and changes over time are possible in cohort studies. So the biases that you have to remember in cohort studies are many people might not come to your study and they might be lost to follow. So the characteristics of people who are lost to follow-up and those who continue to be in your study might be very different, and that may introduce bias into the study results. Cohort studies are in general very time consuming and they are very expensive to carry out. And here you can calculate incidence. You can calculate p-value by using the test of significance by comparing the exposed and the unexposed group. Survival analysis is usually performed for cohort studies with comparison groups, and you are going to say you are going to summarize the results in the form of hazard ratio and 95% CI. This is another example of cohort study. How transmissible is COVID to contacts of positive cases? This can be a community-based retrospective cohort. So risk factors are specified from past records or history. It again proceeds from exposure to outcome. This is an important point that you have to remember is all cohort studies, in all cohort studies, the direction of inquiry is from exposure to outcome. You start with exposure and then you ask whether outcome happened or not. These are usually quick and cheaper compared to prospective cohort studies, but the main limitation is the records must be complete because these will be mostly record-based studies. So how well the records are kept determines how good you can do this study. Again, incidence, relative risk, 95% CI, and p-values can be calculated based on tests of significance in such cohort studies. So we have seen two types of cohort studies. One is prospective and the other one is retrospective. The strengths are, it helps us to calculate incidence. It can help us understand multiple outcomes for a given exposure. So for example, if say you have asbestos exposure as one of the study exposures, you can look at multiple outcomes. It may lead to lung cancers, it may lead to other types of cancers, it may lead to other non-cancerous outcomes as well. So cohort studies help you to understand multiple outcomes of a particular exposure. Clarity of temporal sequence is there. So I told you that cross-section studies have temporal ambiguity, but cohort studies help us to understand temporal sequence. So since you are excluding all the patients who have the disease at the beginning of the study, you definitely know that exposure occurred before the disease occurred. So you can say, you can establish with much more confidence that exposure happened first and then the disease happened. And it is good for investigating rare exposures. For example, somebody is exposed to a particular oil leak, or somebody is exposed to a particular chemical leak. Those will become a cohort and you can follow them up for 5 years, 10 years to identify outcomes which are associated with that particular exposure. The weaknesses are, you might have to follow a large number of subjects for a longer period of time to get some outcomes. So it is time consuming and it is expensive. It is not good for rare diseases. You might end up following a cohort for 10 years, 15 years without any diseases happening. So it is not good for rare diseases. It's not good for studies with a long latency period. So if you think this, for example, studies like diseases like leprosy, where there is a long latent period, cohort studies might not be suitable because at the end of the follow period, you may not even have a single case. And differential loss to follow-up, as I said before, if the loss to follow-up is different between the exposed and the unexposed group, it can introduce biases into your study results. Now, moving on to case control study. As seen before, in the previous study design, cohort study, exposure status was known, right? This was red and this was white, and we did not know the disease status. But here we know the disease status. It is either diseased or non-diseased, and we ask them whether you had the exposure or not. So it is proceeding from outcome to exposure. The direction of inquiry is from disease to exposure or outcome to exposure, whereas in cohort studies, the direction of inquiry was from exposure to disease. So this is an example of a case control study. The investigator is here. Both exposure also has occurred, disease also has occurred, and we are looking back in time. But in this time, the direction of inquiry is from disease to exposure. Please remember, in retrospective cohort studies also, we were looking back in time, but the direction of inquiry was from exposure to disease. In case control study, it is also looking back in time, but the direction of inquiry is from disease to exposure. One of the major challenges in doing a case control study is to select controls for the cases, because cases we all know. If you have a particular disease condition, you become the case. But who are the controls? It is very challenging to select controls for a case control study. Similar to a case, they have all the other characteristics, but the only difference between a case and control is that the controls do not have the disease, but they must have the exact same opportunity for exposure and must be subject to the same inclusion and exclusion criteria. So the golden rule for selecting cases in all other respects. They do not have the exposure, but they should have had the opportunity for exposure. So some of the examples for controls are community-based controls, neighborhood controls, hospital controls, friends, siblings. These are some of the commonly used controls. Some of the classical examples of case control studies are between smoking and lung cancer, ghee applied to the umbilical cord stump and neonatal tetanus, silvestrol using during pregnancy and vaginal endocarcinoma. We will see few more examples. So some of the research questions that can be answered may sound like this. Why only some people get severe disease? So this can be a hospital-based case control study. And as I said before, both cohort studies and case control studies are used for confirming a hypothesis which might have come from a cross-sectional study. And they are useful for identifying factors associated or risk factors of a particular disease or outcome. The direction of inquiry proceeds from outcome to exposure. It is mostly affected by selection bias. The way in which you select cases and controls affect the extent of the study results. If you select a very narrow group of cases, if you select a very unusual type of controls, your study results may not be accurate or representative. Here we calculate something known as odds ratio with 95% confidence intervals, and we can get p-value for comparison using test of significance. You must have noticed in cohort studies, we get relative risk, but in cohort and case control studies, we get something known as odds ratio. Case control studies have certain strengths and weaknesses as well. They are good for examining outcomes with long latency. This was the weakness of cohort study, if you must have observed, because here we are starting with the outcomes, those who are diseased and those who are non-diseased. For example, imagine a rare condition like mesothelioma, where in a hospital, you might get 10, 50, 100, even 200 cases of mesothelioma over a period of time. So they might be rare in the community, but in the hospital, they are easy to find. Relatively easy and quick to conduct, and they are inexpensive. Requires comparatively fewer subjects. That is, the sample size will be smaller for a case control study when compared to a cohort study. And you can examine multiple exposures or risk factors. You must remember that I said in cohort studies, we can examine multiple outcomes, but in case control studies, the opposite is true. We can examine multiple exposures for a given disease condition. The weaknesses of case control study are they are susceptible to recall bias. Since all of the information is coming from the past, we are going to ask the subjects to recall some things, right? We are going to ask them to think back, and cases might be different in recalling as compared to controls. Selection of an appropriate control group may be difficult. As I said before, selection of controls is the most challenging part for a case control study. The rates of disease in exposed and unexposed individuals cannot be determined. Sometimes when we do a case control study, but then we look at the rates of disease among exposed and unexposed. This is not possible in case control studies. This is possible only in cohort studies. Among the exposed, how many develop the disease? Among the unexposed, how many develop the disease? Since we are taking equal number of cases and controls, this will not be possible to do in a case control study. So never estimate incidence or never calculate incidence in case control studies. Case control studies can only look at odds ratios between factors associated and the outcome. Now, whatever I said so far are the basics of these three study designs, but there are multiple variations and multiple complex designs also possible within this. So in a cross-sectional study, it can be either a hospital-based cross-sectional study or a community-based cross-sectional study. These are small studies. Cross-sectional studies can also be large nationally representative surveys where you have multiple levels of sampling, multiple stages of sampling. There is a cluster design. You have to calculate sample weights and use weighted estimates. For example, the NFHS survey, the DLHS survey, or sero surveys, which are conducted at the national level, come under this category. Cross-sectional studies, as I said, can have an analytical component where after the data collection, you can divide it into groups based on some exposure and you can look at associations, but those are only for generating hypothesis. This part is only for generating hypothesis. If you want to confirm a hypothesis, you have to go to cohort and cross-sectional studies. Sorry, case control studies. So a cohort study can be either prospective, retrospective, there can be open or closed cohorts. So these are minor modifications or minor variations of cohort studies, which I would request you to go back and read in a standard textbook. Case control studies, there are many variations of case control studies. The traditional one which we discussed in this slide, there is a case cohort study, nested case control study, matched case control study, and case control studies can also be either population based where you do it in the community, or they can be hospital based. So these are some of the variations or complications of these three basic study designs. So I'm just going to recap the study design, and these are some of the questions you have to ask yourself to select a particular study design. Does your study measure characteristics of a population at one point in time? If your study question is something like this, then you have to use a cross-sectional study. Does your study measure characteristics of a population at baseline and subsequently follow them up over time to determine the occurrence of a disease or outcome? Then it is a cohort study. Does your study compare characteristics or exposures among persons with the disease to those without the same disease? Then it is a case control study. So I'll just pause here for a few seconds for you to take it in. This is a table which I will leave with you to understand how different study designs are suitable for different types of research questions. So a minus here means not suitable, plus means suitable, more number of plus means more suitable, and there are some conditions as well. So if you are investigating a rare disease, then you have to choose a case control study. If you are going to investigate a rare cause, then you have to go for a cohort study. If you are going to test multiple effects of cause, you can either go for cross-sectional or cohort study. If you are going to look for multiple exposures, you can do one of these three. Measurement of time relationship. So we all know only cohort studies can establish the time sequence properly. So you have to go for a cohort study. If you want to measure incidence directly, of course, you have to go for cohort studies. In some situations, you can do case control, but for the time being, please note that it is only for cohort studies. And if you are looking at investigation of long latent periods, then of course you have to go for a case control study. So the take-home messages for this session is the choice of the study design depends upon the research question, the stage of evidence generation cycle. So are you going to confirm a hypothesis, or are you going to generate a hypothesis for a particular condition? The level of evidence required. So as I said, the hierarchy of evidence, cross-sectional study occupies a lower rank compared to cohort and case control studies. Do you want measure of a disease frequency or do you want association? So if you want simply disease frequency, you go for cross-sectional studies. If you want association, you go for cohort or case control studies. And also depends upon the resources available: time, money, expertise, and urgency. How quickly you want the results, how much time and money you have, and certain study designs like case control require a certain level of epidemiological expertise to understand the variables that you have to collect. So it also depends on that. Now, I'm going to show some scenarios, and if you have any answers to these scenarios, you may please chat in the type window, or you can also unmute and we can have a discussion on what study design you will be choosing for a particular scenario. There may be more than one answer to this question, so please feel free to discuss. We have 5 more minutes, so you can also discuss this later on. The slides will be with you, I hope. So recent reports in the media suggest increase in mucormycosis admissions in hospitals across the district. Hospitals are unable to cope with increase in the demand. Some experts have suggested that COVID infection, diabetes, and steroid treatment might be responsible for this increase. You want to do a study to confirm or refute this hypothesis that COVID, diabetes, and steroids might be risk factors for mucor. You have minimal staff and limited funds and time. You need to come with an answer with a reasonable level of evidence, but quickly, so that the risk factors can be identified and addressed. What study design will be appropriate for this situation? I'm getting some answers. Yes. Thank you, Dr. Negi, Dr. Sangeeta, Dr. Shweta, Dr. Malika. Yeah. All of you have said case control study. Dr. Suman, Dr. Vineet, Dr. Deepthi. Yes, case control study is the appropriate answer here because of two things that I said. You need the results quickly, but you have limited funds and time, and you have minimal staff. So the best thing here would be to go for a case control study. But if you had unlimited time and money, you could have set up a cohort to understand the time sequence better. Very appropriate answer. Thank you for responding. Yes, controls without mucormycosis. So the cases will be those with mucormycosis. Controls will be patients who are admitted in the hospital for other reasons, that is non-mucormycosis. Let us look at another scenario. Scenario 2. Vaccination uptake for COVID has been continuously poor in the country. There is some evidence from previous reports that a particular type of vaccine is associated with thromboembolic events such as stroke, CVT, or MI. You have been asked by your institute to carry out a study to verify whether COVID vaccination is actually related to such thromboembolic events. For this situation, what do you think is the appropriate study design? Prospective cohort, cross-sectional, retrospective cohort. Yes, keep it coming. Experimental, prospective cohort. So the majority seems to think a cohort study. There are some outliers who say cross-sectional studies as well as experimental studies. Among the cohort studies, there are two schools of thought. One says retrospective, one says, most of them have said retrospective cohort study. So there is no one right answer to this question. You can do any study design, but you have to justify how you will do it. For example, if I'm taking a retrospective cohort, I would say all those patients who have received COVID-19 vaccine, we will see whether they developed stroke, CVT, or MI. And in the same period, all those who did not take COVID-19 vaccine, we are going to follow them up for 1 year and see whether they developed stroke, CVT, or MI. So this is a retrospective cohort study where you can do it from hospital records. You can also do, you can also start from CVT or stroke or MI. So in a hospital, you take all the patients who have stroke, CVT, and MI, and you take a control group of patients who do not have these thromboembolic events, and you ask how many of them got COVID vaccine. So that is also possible, right? So given here, I have not put any limitations. I have not said about anything about time, money, or staff, or how quickly you want the results, but that leaves more room for creative thinking. Thank you so much for the responses. I have 2 more scenarios. So scenario 3, during one of your casual interactions with the Joint Director for Infectious Diseases in your state, you come to know that scrub typhus has become an emerging problem. But the state authorities are not sure of the exact scale of the burden or distribution of the disease. Without this, they are unable to prepare a response plan and are requesting your help. What study design would you use for this situation? Cross-sectional, epidemiological survey, cross-sectional. Please, I request all of you to at least type an answer so that we can say with confidence one study design. Thank you very much. Keep it coming. Thank you, Dr. Natasha. Thank you, Dr. Ravari. Thank you, Dr. Rudresh. Case control. Okay, interesting. Hospital-based registry, cross-sectional study, cross-sectional. Thank you, Dr. Varalakshmi. Thank you, Dr. Ritika. Cross-sectional. So majority of you think that a cross-sectional study would be appropriate. And I will agree with you, because here we are trying to understand the distribution or the burden of one particular disease in a particular state. So you are going to say how many cases are there in a particular time period out of the total population. You might calculate the prevalence. You might want to understand the time, place, and percent distribution. So for example, you can plot a trend of the past 5 years to see whether actually scrub typhus is increasing or not. So in the first year, there may be 100 cases. In the second year, there may be 200. In the third year, there may be 400. And therefore, you are confirming that scrub typhus as a problem is increasing in the state. You can look at percent distribution. You can say children and elderly are affected, or middle-aged school-going children are affected, or people who are working outside are more affected, something like that. Males are more affected than females. So you're going to describe the particular phenomenon in terms of time, place, and person. You can also identify hotspots of scrub typhus. Which districts are more affected? Within the district, which areas are more affected? So all these things are possible in a cross-sectional study. Thank you everyone for answering that. And the final scenario that I have for you is scenario 4. Many patients continue to have some symptoms like anosmia, memory problems, body ache, fatigue after recovering from COVID infection. But the magnitude and spectrum of this problem, called long COVID, is not known. It is also not known if only certain types of patients develop this long COVID. The dean of your hospital wants to know if they need to open a specialized clinic for long COVID for the benefit of the patient. So what study design would you suggest for this scenario? Retrospective cohort, registry, cohort, retrospective cohort, survey, retrospective cohort,
case control,
cohort. Okay, so multiple answers are again possible for this scenario based on the resources, the time, money, and registry or record, the completeness of records you have in your hospital. You can do one of these studies. But please remember, cohort studies will take time. You have to start from the point where patients are infected with COVID-19 and follow them up for 1 year or 6 months to see how many patients have symptoms at the end of 6 months. But your dean wants to know today if you want to set up a specialized long COVID clinic. So a record-based study would be more appropriate. And as most of you have pointed out, registry-based or record-based study, retrospective cohort might be more appropriate. A case control study might also be appropriate. How come a case control study? Who will be the cases and controls in this scenario? Cases will be those who have these symptoms, and controls will be patients who do not have these symptoms. And you are going to ask them whether you had COVID in your in the past 6 months or not, or in the past 1 year or not. So a case control study is also very much possible here. Is a survey possible here? Yes, a survey is also very much possible. In the community, you could do a random survey, a survey with a random sample of a representative population, and then you can ask how many of them have symptoms like these, and you can group them into two types. One is having symptoms and one is not having symptoms, and you can look at their COVID history. So an analytical cross-sectional survey is also very much possible here. So the point that I'm trying to say here is, for a given research question, there may be multiple study designs which are possible. But depending upon the strengths and limitations and the resources that you have at your disposal, you have to choose the best research or best study design for that particular research question. So I will stop here. If you have any questions, please let me know by unmuting, or if you can type it in the chat box, I'll be more than happy to answer those questions. Thank you very much for the opportunity.
Good afternoon, Dr. Rizwan. This is Geeta Menon. I just wanted to ask you one question, that if we are doing retrospective cohort study on hospital records, right? So if you're looking at the exposure and the outcome both, at some point of time, the patients in the hospital would have had some intervention, right? So
yes.
it is not going to be a pure cohort study in the sense that the investigator or the subjects are not getting intervened. At some point of time, they would be getting some treatment if they have hospital records. So what is your take on that?
Yeah, so we have to make a distinction between who is making the intervention. For example, the patient comes to the hospital, he gets admitted, he gets some treatment, and then he goes away. You as an investigator, did you have any say in that intervention? Did you do the intervention or not? If you as an investigator have not done the intervention, then it is considered a natural experiment. It is happening somewhere, you are just observing it. So there is a fine area, there is a variation of experimental studies called quasi-experimental studies, where what you exactly pointed out comes in that category. So they are called quasi-experimental studies, where you are looking at the effect of an intervention which has happened, but you have not done the intervention, somebody else has done the intervention. For example, say there are two types of CABG that is done in cardiology. One is the open heart surgery and one is minimal access cardiac surgery. So in your hospital, both these surgeries are offered for patients based on some criteria. And you as a researcher come later 5 years, after 5 years or 10 years, and you are looking at the records and you want to see how many of these patients who had undergone a full CABG, the traditional CABG, compared to those who have undergone this minimal access CABG, and you are going to look at their in-hospital mortality, their length of hospital stay, their 5-year survival, etc., and so on and so forth. So that becomes a retrospective cohort. You have not done the intervention. Somebody else has done the intervention, but you are going to follow them up based on the records that you have maintained. So I hope I have answered your question.
Yeah, thank you.
Excuse me. Sir, hello, Pinky here from Jamia Hamdard. Hello, so Pinky here from
Yes.
Jamia Hamdard. So thank
Yes,
you so much for all the information you have provided. Sir, I have a question, like what should be the ideal sample size for these kind of research, and like how to calculate these sample size? And also to this, what are the tools available for the calculation also?
I think a sample size, there is a separate session for you. I will not take much of that. Sample size is basically calculated using some assumptions of what you are going to estimate. So if you are going to estimate prevalence, or if you are going to estimate incidence, or if you are going to estimate relative risk, odds ratio, hazard ratio, whatever you are going to estimate, you need an assumption of what that is going to be. Say, for example, hypertension, you are going to do a survey on understanding the prevalence of hypertension in a particular population. Then that expected hypertension prevalence becomes your input for sample size calculation. I often use a tool called OpenEpi, which is a freely available open software which is available on the internet. And there are some examples also given on that website through which you can try to understand sample size calculations for some of the common problems.
Hello. Hello.
Yes.
Sir, this is Anuradha.
Yes, madam.
Sir, I just wanted to know, is there any particular proportion between cases and controls, sir, or it is only 1:1 ratio?
No, you can use multiple controls per case. You can go up to 4 controls per case. That is the maximum limit you can use. And the reason for increasing the number of controls is to increase your sample size and therefore increasing the power of the study. Power of the study refers to the ability of a study to detect a clinically meaningful, statistically significant difference between the cases and controls.